afternoon, everybody. You guys are to be commended to be the diehards on a beautiful spring day, to be in the session today. My name is Dr. Loretta Fairchild. I am Rosemary Nelson and your moderator. Today, Rosemary had a family emergency. Her brother's in the ICU and sends her regards and could not be here. So it's my pleasure to introduce this panel speakers today. We'll first hear from the representative from the VA, and then Dr. Kathleen Frisbee to my right, and then Dr. Hon Kwok will speak on behalf of his experiences with the DoD, and then I will follow with my experiences with the DoD. We'll keep the presentations to 15 minutes each in length, and please hold your questions until after all three presenters are complete. Our first speaker is Dr. Kathleen Frisbee. She is the Director of Web and Mobile Solutions in the Veterans Healthcare Administration. She leads a number of mobile health initiatives for the VA and clinical mobile applications, both for veterans and clinicians. These initiatives focus on supporting the VA delivery of patient-centered care. Kathleen has worked for the Department of Veterans Affairs for over 25 years. Her undergraduate training is in pharmacy. She earned a master's degree in public health and is completing a PhD in systems engineering at George Washington University. We're pleased to welcome Dr. Kathleen Frisbee.
Well, thank you. Thank you for having me. I just want to clarify one thing. I'm not yet a doctor. I'm still doing my dissertation. I hope to be someday, but... So what I'm going to do is take you through the journey that VA has been on in mobile health. And before I do that, I want to acknowledge the support of Roger Baker, our CIO, and Dr. Petzel, the Undersecretary for Health. Without their partnership and their support for all of this, we would not be as far along as we are. So this is just a little snapshot of the VA. There's about 22 million patients or veterans out there. We serve about 6 million per year in the VA. 8% of those are women. We have over 800 outpatient clinics, 152 VA hospitals, 280 vet centers, 131 national cemeteries, and 58 VBA regional offices. What this slide represents is what we're trying to accomplish with mobile health. The gold dot represents the average number of minutes per year that a patient spends with a provider, 100. The big white circle represents the number of minutes in a year. And the amount of money that we spend just on that gold dot, the Army alone is $13 billion. What we're trying to do in mobile health is we're trying to extend healthcare into that white space. And so what we're doing with mobile health is we think of it as an engagement model. That is, we're trying to reach patients who aren't necessarily in the treatment system. So that funnel represents the treatment system. And as you move down that funnel, you become higher risk and more costly, eventually dropping into institutionalized care. What we're trying to do in mobile health is to engage patients sometimes before they even get into that funnel. So the goal for the mobile health vision is to engage patients and their caregivers, to provide support when and where they need it, to increase the amount of sharing that goes on between veterans and their healthcare teams in terms of communication, and to increase healthcare providers' efficiency. So, if you leave this presentation and there's only two things that you remember, these are the two things that I want to tell you. The first is that the ability to exchange information with a healthcare team outside of the typical visit is going to be a huge transformation in healthcare. And, it's my opinion, that healthcare systems will compete on how effectively they can use that patient-generated data to improve health. What that means, though, is healthcare systems are going to have to think strategically about how to summarize that information so it doesn't overwhelm providers, and how to construct algorithms that run in a standard way on mobile apps to help patients manage their own health conditions. So that's the first thing. Patient-generated data will be a commodity that healthcare organizations compete on. The second thing I want you to remember is, it's our view that the next electronic medical record will not be a large monolithic computer application. It will be a series of mobile apps that have been designed around discrete workflows where providers download the specific apps that are relevant to the workload that they perform. And that, in fact, will produce kind of a tailored EHR for each clinician. And that, in fact, will be the next electronic medical record. So those are the two things I want you to remember. The first app that VA ever produced with DoD is the PTSD app. And Julia Hoffman is right here in the audience. And she worked on this, and it's 80,000 downloads in 70 countries. And this has gotten a lot of publicity. Now, this is the first one, and this one did not take any data and share it with the healthcare team. The next step for us in the VA was, how do we design apps that move data from the electronic medical record to the patient and move data from the patient to the electronic medical record? That was the next step. So we had to develop a strategy. And I'm going to talk about this strategy a little bit more, but there was, in fact, two pieces to that strategy. One was the infrastructure. We knew the most important thing was security. We had to do it in a secure way, and we had to put all of the infrastructure in place that allowed it to be done in a secure way. And so I'm going to talk at the end of the presentation about all of the infrastructure that we built out to support mobile apps. And then the second thing we did was we said, you know what, we're not going to design apps as siloed applications. We're going to think about apps as a suite of apps that are designed to work together to improve healthcare. So, what this slide provides is the timeline of what we've accomplished so far in mobile apps. And it actually began in 2011 with a mobile health pilot at the Washington, D.C. hospital. And the purpose of that pilot was to look at what are the security issues and how do we mitigate them, and how will providers respond to mobile apps with apps that have been designed for providers. So that was the purpose of that. Once we finished that, we began building out the infrastructure that I'll talk about, but we then began designing other apps. And the first thing we did was we looked at, okay, how can we design a suite of apps for veterans and caregivers? And I'm going to talk about that. And then the second is, how can we design suites of apps for providers? And I'm going to talk about that too. I'm going to talk about each of these specific projects. And that brings us right up till probably 2013. So we've only been at this for 2 years. So this is the DC pilot that we had in Washington, D.C. And again, it was to look at security issues and also to look at some apps that would help providers. This is an example of a summary of care app. What this did was it took data from the electronic medical record, in this case the labs, and it displayed it graphically over time and also provided the 508 compliant data on the left-hand side. And you can see all those little icons on the left. You may or may not be able to see them, but they displayed medication data as well. I believe it was patient demographics and a small set of data from the electronic medical record. So the pilot was a 3-month pilot. There were 30 providers involved. 15 had iPads, 15 had iPhones, and then there was a series of surveys that were administered to the providers so that we could understand what the issues were. And we have two of the folks from the DCVA, Dr. Dane Bent and Neil Evans, who are here, who actually participated in this pilot. This is the survey results from that pilot. You can see that a large proportion of the providers said that there was a large positive impact or a moderate positive impact from the mobile apps. They increased their productivity, their ability to share information with patients, their ability to communicate with patients, their ability to review important patient information, the ability to communicate with other providers, and their ability to deliver health care. The orange, somewhat dissatisfied about the ability to review important patient information, was because, I believe this is true, once we gave them some of the information, they were dissatisfied that they couldn't have it all. So that was the reason for the dissatisfaction. So this is the second pilot that we've rolled out, or we're rolling out in January. It's taken a year to develop all of the apps for this pilot. This is a pilot for veterans in the Family Caregiver Program. And what this is these are seriously injured veterans that are being taken care of by family members or family caregivers. The caregivers receive a stipend from the VA to provide that care. And we designed a suite of apps for these veterans and their providers. And we did that by doing focus groups, where we went to the caregivers and said, okay, what kinds of apps do you need and want? So we got that list, and then we began to develop them. So in August, we sent out 4,000 letters to people in the program asking them if they wanted to participate in this pilot. 1,200 roughly caregivers answered that they did want to participate in the pilot. We sent out a letter notifying them that they would be selected for the pilot, and we're anticipating in January that we will distribute 1,200 iPads with the suite of apps loaded on it, and we will then assess the effectiveness of the suite of apps in improving healthcare. This is a listing of the apps that are on in that suite for the caregiver and the veteran. There's a pain app, which is really a very impressive app. There's a lot of information that it collects about pain. Right now in the electronic medical record, all we have is a single pain score. So this is a huge amount of additional information for providers. There's a meditation app, an e-journaling app. The e-journaling app was the app that was most requested by caregivers. It provides a way for them to basically log activities of the individual that they're caring for so that they can share it with their healthcare team. It also allows them to incorporate information from the private sector into that journal so it can collect it all in one place. Prescription refill, the summary of care, provides information about the electronic medical record, from the electronic medical record. It's labs, it's meds, it's radiology reports. We're doing progress notes. So there was a whole release in the Annals of Internal Medicine on open notes. We are actually doing that in this project. There's a PTSD coach, which leverages the work that Julia Hoffman did, but this time it actually takes the data and puts it into the medical record, so it's available for the clinical staff. Mobile secure messaging, a health advocate app, which basically allows you to assign surrogacy functions to your caregiver. A notification app that allows the healthcare team to send notifications to the patient, and also allows the patient to set up reminders, or the vet or the caregiver to set up reminders for themselves. And then appointment requests integrated into the calendar on the device. The study that's planned for this to evaluate the effectiveness, there's 3 components of the study. There's a primary quasi-experimental study where we basically look at the burden and stress levels in the caregiver population that have the iPad and compare it to those that didn't. And we collect that information quarterly, record it into the electronic medical record, so we have a large historical base to draw from to determine whether there's been a change. In addition, we're looking at changes in healthcare utilization, ER visits, admissions, no-show rates, and the other one is escaping me. Outpatient visits with the provider is the 4th one. And then we're doing a longitudinal cohort study where we're looking at just the population that received the iPads, and we're looking at preparedness levels. There's an instrument that you can use to look at how prepared the caregiver is. We're looking at that, if that's changed over time, pre-post study design as a result of the iPad. And then finally, we're doing a qualitative, well, I should add, the longitudinal study also has another component, which is using decision support data mining tools to look at what is the optimal combination of apps, that is, the utilization of apps that are most related to changes, positive changes in outcome. So what combination used frequently seems to be most associated with positive outcomes. And then finally, there's a qualitative study, which is we want to understand why some people used them and some people didn't. So we're calling high users and low users and trying to understand what the factors were that drove that utilization. 1 PI. This is the Launchpad. I have to say, this credit goes to Agilex, our contractor for this. This was a really brilliant idea on their part. You know how you have apps on your iPad and they're all over the place and you can't find them? And well, this idea was that when you go to essentially the VA's app library and download a VA app, it's got some code in it that moves it into this little mini app store. And all VA apps go here and live here. And what that gives you is single sign-on across the apps, so you don't have to sign on individually to the apps. And it also provides context management across the apps. So that's the Launchpad concept. We're going to have that both for veterans and for providers. And it also has resume functionality. So if you're in one of these apps, they're going to be these are iOS apps, but we're building the next round in HTML5. If you leave one and then you resume on your desktop, it'll resume back where you were. This is a list of some of the other apps that we currently have that we're working on. These are going to be rolled out over the next 18 months. And I'll just highlight some of the ones that I think are really innovative. We have a biosurveillance app, and it's kind of like if you're a weatherman, if you're participating in that weather program where you help report weather. But this is, you're a veteran, and we know who you are because you've logged on, and you can report flu-like symptoms or foodborne outbreak-type symptoms and be a biosurveillance reporter. And we can use the GPS on your device and start beginning to get a lot of early information about where there may be outbreaks. Another set of apps are the Coumadin app, the immunization app, the wound care app, and the ICU app. Those apps have been designed around discrete workflows. So the concept is that if you are doing an immunization and there's 4 concrete steps to doing an immunization, now in the electronic medical record you have to go to 4 different places to do that. You might have to get consent in one place. You might have to look up immunizations in another place. This bundles workflow together around specific tasks, increasing the efficiency, hopefully, of providers. This really kind of goes to that point, which is the next electronic medical record is going to be apps that are designed around discrete workflows. So, of course, then there's all the other stuff. We pretty much have reading the electronic medical record down. This is going to be writing to the electronic medical record. Other types of, we're going to do mobile imaging. Another one is the kind of the remote patient monitoring. So we're creating a connector. Okay, time. Connector that's going to allow a lot of these biosensors and these kind of home monitoring devices like scales and blood pressure cuffs to allow the veteran to subscribe, and that data then can come in and it can be used by the healthcare team. And again, this goes back to my first point, which is that is going to be the thing that transforms medicine. So we're developing a universal connector that will allow us to connect into all of these devices and bring that data back to the healthcare team. Okay, I'm out of time, so I'm just going to fly through these real quick. Security, it's all about security. We spent a whole lot of time on this. Everything's double, triply encrypted, so secure. We're creating this mobile applications environment. It's cloud hosted. This is where all of our apps will be hosted. And not only that, not just production apps, but the development environment. And we're hoping to share this with DoD. The point is that we can enforce standards here, common web services, common code libraries. So everybody now, common tool sets, come develop an app, come. And we'll tell you at the end how to certify it, and we'll give you everything you need to know up front in this applications environment to do that. The Terramark VA Cloud, yep. We're going to have 2 enterprise app stores, one for providers, one for veterans, actually called a library. We will not let an app be published under the VA's name until it's gone through a certification process. We've worked down in the bottom right-hand corner our logo. All of these things have to be passed before you get into the App Store. And, you have to have usability review. You've got to have 508 compliance, all that stuff, security and privacy. So we worked that out, and that's the end.
Thank you, Kathleen. Our next panel presenter is Dr. Hon Kwok. He is CEO and Director of DiversiNet, a company with a focus on providing healthcare organizations with an agile, secure mobile application platform for secure messaging. Dr. Kwok is a recently retired Army colonel and was Chief Information Officer of the U.S. Army Medical Department, an $11 billion healthcare system with more than 60,000 employees. He was the Army's first Chief Medical Information Officer prior to his promotion to CIO. And he also previously served as president of the American Telemedicine Association, leading efforts of global health and standards development for telehealth. He has also headed the Advanced Information Technology Group within TATRIC, the Telemedicine and Advanced Technologies Research Center at Fort Detrick, Maryland, which has served in the U.S. Department of Defense IT Research and Development. Dr. Kwok holds a medical degree from the Uniformed Services University of Health Sciences and completed a fellowship in dermatology at Walter Reed Army Medical Center. He's a distinguished graduate of the U.S. Military Academy at West Point. Dr. Kwok.
Yeah, I'm going to have to watch what I submit, or who submits my bio. I'm going to have to really reduce that. But thank you for being here. I'm really surprised that in this weather in December that you guys are here. So we may have to check your mental state here. So obviously, I just recently retired in December of last year. So I share that because the folks that were originally supposed to be scheduled to actually present that know the depth of this information around what the Army's done with the MCARE program. I'm just representing some of the slides and adding what I believe was the lessons learned and how it's moving. I think we're very jealous because as I look at Kathy, DoD really has taken advanced steps towards that, and so again, we're very happy and jealous at the same time of how quickly you guys have been able to really achieve the success you've done. So with that, we'll get started. We in the MHS, I still say we because I'm forever a veteran, but military healthcare system it's a 9.2 million beneficiaries, and what many people don't know is that we have some of the same challenges commercial sector does, in that 60-70% of the healthcare is actually done by the local network all around the world. We're in every time zone. Obviously, we have the combat and other things, but really the issue for us is how do we take mobility, and I think that the way, when I talk to Steve Stephenson and others, it's really this concept that, look, mobility is here to stay, we know where it's going, but fundamentally, as Kathy said, this is about can we figure out how we get to know you as an individual and get you to change behaviors in the most optimal way. I believe that is the journey that we're on. And these standalone apps is really not going to get us there. And here's an example of what it means to get activated and why it matters. So as you look at different types of variables, it makes sense that if you are activated, you're engaged. And again, you can talk about how do you get a patient to be activated. So we're going to get, just like alert fatigue and all these other things with mobile apps. How do you get them to really engage? And I think we can talk, if we have a little bit of time, about how do we do that. So the challenge again is that there's lots of apps. And I think there's going to be like this McDonald's commercial. It's like instead of fries with that, you want an app for that. But I think that the engagement, as Kathy said, has to be bidirectional. These apps that are very consumer-facing only really cannot achieve the level of success and the outcomes that we're looking for. And interoperability becomes key. And we need to start out by looking at the common data elements. And I would offer that we should take the work that has been done by Estabrook and National Library of Medicine and these determinants of health, these domains of health, as a common way of defining these determinants we think that are the ingredients to help us understand who we are and why we make decisions. And whoever's interested, let me know, and I can get you those links. And then obviously the workflow is interesting. So my daughter, for those of you that weren't in my other talk, my daughter 4 weeks ago came and said, hey Dad, I know you're working on this mobile thing, but I got an app today after my visit. I said, well, that's so cool. It's actually, adoption's occurring and all that. And then it made me clearly understand that was one vaccine, one app. And I'm like, oh my gosh, we're on this journey of EHR all over again. Patients aren't the same. And yet, it reminds me a lot of my first medical school classes or some of the college classes I took. Getting in a classroom of 200, 300 people, professor comes, and he just gives his lecture. And it's expected that all of us will get it, but we know what happens. In healthcare, I think we're doing the same thing. I think we know that we're different. We go to Starbucks, we go to other places because they know us. Because they know that I like caramel macchiato, right? In healthcare, we don't set up profiles in that type of context. And I think that's really one of the key messages that I want to set out. That I think if we're going to learn, because the premise is this, the premise is that we don't know how to engage patients today. We have barely scratched the surface. So let's build a system in which we learn together collectively, not you creating your data model on an app, learning what you can, but you can't apply it across that. And so Kathy's work and Kathy's outreach into the DoD, I think will help us in that type of work. So really the adoption has been slow, and I would argue that while the energy and this conference is really getting big, no one's figured out what the right recipe is in terms of a repeatable model for adoption. And I believe that the answer, in one sense, we have control for, in one sense, we don't. And what I mean by that, imagine if we had an actuarial and a patient activation model, and we could determine your adherence number. What if there was such a number, and it was tied to your health, your premiums? It is when that begins to happen that will fundamentally begin to change, where I bet I will use my app if I get 10% discount on my premium. Plus, but to do that, I believe we have to get to the determinants of health. I think we don't know our patients as the consumer. I think that's one of the fundamental issues that we have today. Here's an example of what it means. So it's a hypothetical example where this diabetic patient, it turns out for this patient on the model shows, this patient wasn't motivated by dropping the glucose. They were motivated by number of injections. Whether it's language preferences, it's how we learn, it's all those things that don't get collected in the EHR. So the Army built for the Wounded Warrior Program. They have soldiers in the Army Reserve National Guard that have come back from Iraq and Afghanistan. They have traumatic brain injury, stress, depression, all these conditions. and there were case managers that were telephonically trying to call and remind them to take the medications, to remind them to keep the schedules, and we had no-show rates, and we just didn't have any idea what was going on because, these phone numbers weren't active and all that. And so they essentially created, using our platform, the Mobile Secure platform, they were able to build really a case management app in which you can track moods, you can track a number of different things and create an interoperable set of applets and functions in there. They did it in 2 stages, but these are the questions that they asked. So it's not quite the sophistication of the VA, but these were the questions. Again, I didn't have anything to do with this, so I was... No, I mean that in a good way, in that there are a lot of people... No, there were a lot of people that really, including Holly, Jeanette, Steve, and others, that really deserve the credit for doing this work, because this wasn't easy, because you can imagine DoD and the way they look at security and all that was pretty... To get this study launched was no small feat. So the workflow is that the care teams or the case coordinators essentially enter their schedule, their messages. That message is sent to the soldier's phone, and then they respond, and then that data comes back to a portal, and then the case managers get to see what's happening and then engage them. So it wasn't a provider, it was a case manager in this case. Well, it is. So there are 2 research phases. I'll show you the phase 1, and then the phase 2 just completed, and they're doing the draft publication, and so I can't release that until they actually release it. So, but my understanding verbally is that it went very, very well, and there's some lessons to be learned from there. But this was the distribution, about 497 volunteer patients, the distribution of where they were across the different U.S. sites, different operating systems. And again, this is part of the challenge, right? The operating systems are changing. How are you going to maintain building apps that go across these platforms? It becomes very challenging. And then types of interactions or messages largely were health and wellness tips and appointment reminders and some general announcements. And what's interesting here is that it turns out that when you message, it does matter. There are these windows. And this is, again, to the point of what are we learning about when we can engage them and so forth. And then in terms of some of the patient responses, does it help your ability? And most of them felt very strongly that it helped them keep their appointments, and the data actually showed that they kept more appointments. And then in terms of providing the valuable information, generally there were yes. And then the same thing in terms of communication. And I think this is a critical point, that these standalone apps really don't do the trick, because whatever we do, we need to enhance the relationship between the provider and the patient and the care team. If we don't do that, I believe fundamentally we will not be able to achieve the success we're looking for. And this is a quote from one of the wounded warrior, one of the soldiers who used the app that had this quote. So I think it gives you a sense that it does matter. I think also when you ask a patient, so I as a physician, when I ask someone, we typically ask the question about drinking, right? So if you ask 3 out of the 4, I forget exactly the number, it's been a while. As a dermatologist, I don't typically ask this question, but when I was an intern and general practitioner, I would ask, how many glasses a week do you drink, blah, blah, blah. The way they answer it in front of me, looking at my eyes, is different than what they would do on the mobile phone. It is very amazingly interesting. And so I think we should take advantage of that, because that gives us insight in ways that obviously we're not getting. So the next steps for the Army, they won the Army's, this isn't Army Medical, the big Army gave them the award for the greatest invention. Obviously phase 2 publications are being finalized. It's actually being moved from research to operations and to Submitted, which is the organization that actually supports the operational day-to-day. It's going to be expanded to all the CBWTUs, which are the clinics where the case managers manage patients, and then they're now creating pain management and all the other different apps that are being rolled out. And then we're having some discussion about enrolling that into the other services and so forth. And the model that they're using, because of the level of security, they require FIPS 140-2, which is what we do. Essentially allows a level of encryption and authentication to the user. One of the big things is about the passwords, like how many passwords do you have? And probably average 25, I would say, or something of that nature. So in TRICARE Online with DoD's patient portal, one of the key issue was people would forget their passwords because they wouldn't use it that much. Well, with this, you can actually get a 6-digit code that will never change because the passwords are changing dynamically in between the mobile device and the server. And then what really the Army's effort and what we're going to do next is to really build upon that. But remember I talked about those preferences, those determinants of health? We believe that that should be in every core foundation of mobile apps, and so we're building that into our wallet. We're calling this concept a mobile health wallet, in which you create or download, enter, manage, share your data, and then connect it back to the providers using interoperable applets. And why interoperability is important is because of examples like this. Imagine you came to see me because you had a death in the family and you're not sleeping well, have some signs of clinical depression. I give you a medication, and when I trigger or order for a medication to help you sleep, that triggers 2 applets as an order. One is a medication adherence applet that gets triggered, that activates that medication reminder. Second, it has a mood tracker that says, how are you doing today on a daily basis? It is that collective type, crude example, it gives you a sense for it is that type of data coming together that is going to begin to help us better understand what the patients are really doing. So again, we think we need a new model for engagement that is more patient-centered. And this is for those that are interested in the data elements, this is the reference, the Esterwork from the National Library of Medicine. We talked to Clem McDonald the other day, and we're pretty excited about bringing that together as part of this work. And then, again, here are some of the specific elements like sleeping quality, risky drinking. None of this data is at the hand of the providers when it matters. And we believe that that type of data can only be gathered in any real time on the mobile device. It can't be collected in the clinical setting. So with that, thank you very much.
Thank you, Dr. Kwok. And last but not least, I'm going to introduce myself. I'm Loretta Fairchild, a nurse, a retired Army Nurse Corps officer, a senior healthcare administrator, and a researcher in mHealth, telehealth, telemedicine, telenursing. For 13 years, I've been president of iTelehealth, Inc., which has provided expertise for telehealth and mHealth training and research, development, and implementation of advanced technology systems. In the military, I served as the clinical director for the telemedicine testbed in the southeast U.S., standing up approximately 20 telemedicine applications in the 8-state region in the southeast, and worked very heavily with TATRIC and Telemedicine Advanced Technology Research Center when Dr. Kwok was in uniform. I was a collaborator and co-sponsor of the 2004 International Telenursing Study, which over 700 telenurses from over 36 countries responded and are participating and actively tracking, monitoring, and using eHealth, mHealth technologies. I'm a fellow in the American College of Healthcare Executives, and I am currently the chairperson of the International Telenursing Advisory Network in Geneva, Switzerland, of the ICN, International Council of Nurses. We have over 200 countries that participate in learning about and advancing the work of nurses using mHealth and telehealth technologies. Today I'm going to speak a little bit about mHealth and telehealth and where some of the intersection may be and how we came to this place. And also I am going to be speaking about my own journey within military mHealth applications. I'm not here as a spokesperson of the Department of Defense. These are my own opinions, so that's the disclaimer. I'll describe what I found to be key mHealth success criteria and also provide an invitation for you to participate with the military health system in an activity. Dr. Kwok could not have set me up better in terms of his presentation. The body of knowledge of consumer informatics which is patients using and accessing mHealth and electronic information and knowledge, is at its infancy. We have a lot of work to do with how patients interact with technologies, how they use it, and their preferences. And so this is an emerging body of informatics study and science that actively needs to be pursued, particularly in the mHealth arena. One would say, what is the relationship between telehealth and mHealth? And there was an interesting blog recently, and if you go on Google and what is the difference between telehealth and mHealth, what the discussion was about is that telehealth is an umbrella term, and telehealth or telemedicine can use wired or wireless devices and technologies. And mHealth is the wireless, and telemedicine is the wired. So that's kind of the current thinking. And then I just wanted to make sure that you all have the definition of telenursing, which is nurses who are using and managing and responding to all of these alerts and data and the monitoring of the content, as well as our colleagues that are physicians, nutritionists, and the other members of the healthcare team, therapists who can utilize these data and make all of these technologies actionable in terms of improving outcomes. The military has a term called force multipliers. And in our estimation, mHealth can be a force multiplier. And it's a very simple term. The whole is greater than the sum of its parts. So you've got a giant aircraft carrier. It is a huge, and it's to me, it's like the healthcare enterprise. It's got all the staff and the facilities and the technology, and if you're bleeding and you need surgery, you go there. The helicopter is more like mHealth in that it's mobile. It can go off and do things, but it always comes back to the mothership, and the data and the information, or the people they go rescue will come back to the enterprise. And so, yes, the helicopter has good short-range capability and can do many things on its own, and the aircraft carrier can do many things on its own. But when one puts a helicopter on an aircraft carrier, then you have much more capability and are able to do many more things than each can do independently. So I'd encourage you to think of mHealth as how does it relate to the enterprise, and how can we leverage it to make improvements that are greater than the sum of its parts. This is a little bit about my journey in mHealth and telehealth. 1996 was the electronic house call. This was took two guys in a truck to install this home telemedicine system. It was run over Jones Intercable, the local cable company in Augusta, Georgia. When it rained, it didn't work. And so it was quite interesting. It had a touchscreen interface, and all of the tower and all that was hid behind a smoked glass cabinet in the bottom. And it had all the peripherals that the patient attached. The cost was $20,000. At the time, in '96, this was one of 3 home telemedicine applications in the country. The other 2 were in Minnesota, because it's cold up there and people did not want to drive. And so that was the genesis of that home telemedicine initiative. And the nurses would call the patient up, interact, hook up all the stuff, collect data. And the outcome was that even though it was expensive, it didn't work half the time. Patients started using the devices, and my golly, we kept them out of the hospital. The light bulb went on. When this happens, I feel this way. When I do this, I get this number, and so they began managing their own disease. Fast forward 8 years to 2004. At Walter Reed Army Medical Center, and I participated in all these things, which tells you how old I am. This was a study of taking a little suitcase home after you have your open heart surgery. So you have your open heart surgery, you're sliced from your neck to your navel, and they're saying after 5 days, see ya, come back in 2 weeks. So this was an off-the-shelf technology. We didn't build any of this, but patients took it home. They rolled it in the suitcase, worked over dial-up phone with video phone and monitoring devices, and the cost went down to $5,000 per unit. So we're talking $20K, $5K. And the same thing happened. The telenurse would call the patient up and monitor, collect data, and do the visit. And then the outcome was we reduced infections from wound infections, and we kept people out of the hospital because we caught complications before they got to the point of admissions. Fast forward to 2012, again, another 8 years later, and where we are is working with a DARPA, Defense Advanced Research Projects Agency, the home of the founders of the Internet, on the non-intrusive health monitoring for post-battle wellness management. And the same systems that cost $20,000 and $5,000 are now in the platform of a watch, which I've been lent, and here it is. And it is basically a continuous acquisition device, and it collects data every 30 seconds from the wearer, and it's embedded with sensors that collect various parameters. And one can use different attachments. This is the Bluetooth pulse ox, which you all are probably familiar with. And it can collect data that then also goes over the network. It uses a Zigbee mesh network and the Bluetooth additional peripherals if needed. And it's a low-power network. The battery will last 3 days, and people can wear it. The cost, we're down to $1,000 to $2,500 per unit, depending on what peripherals are used. What's interesting about this is the nurses don't have to engage the patient or look at data every day. It has an intelligent learning platform on the back end, so it learns what's normal for the patient. And if there's a deviation, then it sends an alert. But if everything's going fine, the nurse doesn't have to actively engage with the patient unless they want to. And what is the outcome? Decreased hospital admissions, same as back in 1996. So it's been kind of the trajectory of where we have been and where we are currently today. The challenge with the DARPA project was to have a device or a system which was a post-combat safety net using sensors, networked cognitive software, and being able to provide intelligent, predictive learning and alerting. They wanted it to be non-intrusive and acceptable to the warfighter and to have low cost. So they came up with the watch platform. Now, this has been tested also with Special Forces at Fort Bragg, and what they did is took the watch capability and put it in sticks, and so the sticks can go into your various sticks depending on what one would want to measure, if it's blast pressures, EKG, blood pressure. So the sticks can be worn as sensors, and individual sensors. The active military version of the watch, another platform beside the sticks, is a ruggedized version of this pretty pink watch. It is basically establishes a personal network so that one can see where the warfighter is, what they're doing in terms of activity, if they're moving or not moving, and also collect the parameters that you see here on the left. So again, this has been tested under test conditions within the military. And the idea is that once one leaves the battlefield or the operational theater, then you're in the hospital. So this can provide a wireless network where one wears the watch as they're recuperating. So they're get up and walk around for the first time, they get transferred to the ward, and they're moving for the first time and going to the mess hall and going to the dining facility so they can wear the watch to assess for falls and other types of potential problems. The intelligent learning platform piece of this was developed with Brooke Army Medical Center data. 650 patient records were acquired, and I am no expert on predictive modeling and machine learning, but the people that did this at A-Frame Digital were involved in the finance world. So they built the models for the first credit card detection. You know how when somebody uses your credit card to buy a $5,000 ticket to Jamaica, and you never do that, and Wells Fargo Visa cuts you off? Well, it's kind of, they said, if we can develop that for credit card fraud, why can't we do something when Aunt Mary gains 4 pounds from her CHF before she has to go to the ER? So it's like, duh. So this is the approach that was used are the same models that were built within finance and are being applied to the data that's being collected from this watch. So this investment on the part of the Department of Defense is being tested within the military, but they also call it dual-use technology in that it is being used in the civilian sector live as we speak. My little pink watch is active, and you can see that this lady, who is in an assisted living facility, says, I don't want to take it off, and oh, by the way, she has much more time than I do because she has bedazzled her watch. She put nail decals on it that would go in your fingernails, and she put rhinestones on it, and people love their watches. It's a piece of jewelry, right? So it's very low stigma. People don't feel like they're old people wearing it around their neck and having to push a button, and it's very personalized, and it provides them a sense of independence and security. It is currently in use in civilian healthcare in hospitals, rehab facilities, long-term care, assisted living, and some home settings. It's actively installed in 15 facilities in 6 states, and also Australia is very heavily adopting this at this point in time. And of course, with the seniors and trying to keep folks out of nursing homes, there is obviously a huge market for this. And there, if you go to Best Buy, there are so many watches that monitor heart rate, right? I mean, it's just like, oh my gosh, there's just way too many. The difference to me, having been in this game for a bit, is the intelligent learning and alerting platform. It's what you do with the data and how you free up the providers. And also, I should mention that alerts do not go to a doctor or a nurse at first blush. They go to a neighbor, a friend, a daughter, a son, someone who should be the first one to check on somebody. So we're not engaging the healthcare system unless it's needed. And this is basically how it works. There's a wristwatch monitor, which I'm wearing. There's a, this establishes the wireless network. It just plugs into a wall socket. It's called a Wally, wall router. And then you can use additional devices like a digital scale if needed. And then you charge the watch every 3 days. And that's really all there is. So the 2 guys in the truck are not needed. Patients can have this installed on their own, or a friend, or preferably a teenager in their family will just hook it up in a heartbeat. What it does provide are real-time status and alerts. There's a dashboard of those people that are wearing it, what their battery status is, are they on the network or are they not. If a person goes on the network, it can be programmed to alert right away. So for Alzheimer's and wanderers, if they leave their house or leave the facility, beep, there is an alert. I have to share with you a story about Vinson Hall, which is a large military retirement facility out here in Northern Virginia, and there's an admiral, retired Navy nurse, who is the director. And they've tried all kinds of elopement technologies, I mean everything. They had people over there that were POWs in World War II that escaped from POW camps. And believe me, she said they've tried everything. Those guys will escape from that place and they find them on I-95 all the time. So, yeah. But anyway, so they're always searching for things that work, and they have adopted the watch, and we're a beta site, a test site for it. So it provides real-time alerts so that one can get an alert that says help requested, and you can get an alert on by email, text, or a phone call, so you don't have to be near your computer. It tells your location. You can see where the person is as soon as they pop up on your phone. And it's just a different, kind of the next generation of a monitoring and intelligent learning platform. So along the way, some of the success criteria and key lessons learned that I found is technology can empower and inspire consumers to improve health outcomes, but we don't really yet have a grasp of the body of knowledge of how and why and how we can leverage that, and that consumer informatics body of research needs to be done. Technology will change. As you can see, from 96 to 2012, became smaller, cheaper. However, the improved clinical outcomes using the technology should not change. And so focus on outcomes when you're looking at building, purchasing, or using mHealth technologies. And also ease of use and integration with the clinical workflow is paramount. I mentioned I had an invitation for you all. I'm pleased to be part of a team with MDM Strategies to work for the Army at Tatrick, to do a piece of work from from last month through February of 14, to identify and research patient privacy, identity management, and agile best practices to use in the military health system. And I know that many of you, or most of you, are here in the civilian sector, and so I'd like to invite you to participate if you have unique patient privacy and identity management best practices to offer, if you have technologies in those domains to offer, and if you're a researcher in patient privacy or identity management, we'll be having an invitational research working group to develop a roadmap for research for privacy and identity management in mobile health solutions. So please see me if you'd like to be part of this work and participate. Thank you. I'd like to take any questions at this time from any of the panel members. Yes, ma'am.
My name is Allison Jacobs, and I'm the CEO of a company called Telehealth, and we put modular home accessible dwellings on the side of caregivers' homes.
Oh.
And we're building in smart house where we monitor ADLs and all things like that. But we also want to have the health capacity. So with the watch, a big thing is sleep patterns. Does that also monitor sleep patterns? And also, is there a monthly charge for the monitoring? How does that work?
There is a monthly fee for having the access to the data and the alerts, and I want to say it's like $59 a month or something like that. As far as it does sense activity, so you can do movement, so you can see if people are getting up, if they're sleeping, and also you can set an alert for activity. For example, if you know your mom's up every morning by 9 a.m. and she's not up by 9 a.m., you can get an alert to check on her. So it is very, activity is a big part of the sensing and the training and the alert. Yes. Ma'am?
A question for Kathy. You were talking about the app for My Goals. Is that the same content as was developed for My Recovery Plan, or is this different? The My Goals stuff, is that different?
Well, we're trying to bring the two efforts together. So the My Goals is initiated by the Office of Patient-Centered Care, and the My Goals was developed by Mental Health. So it is our goal to combine the goals.
First, I'd like to just a comment. I'd love to have one of those. I actually fainted in the restroom at work a couple of weeks ago, and all they could tell me was overstimulation of my vagus nerve after eating Chinese. I don't understand. Hospitalized me for 2 days. Nothing. Okay. It wasn't funny, though, at the time. Would you please, for me, I support the mymedicare.gov Blue Button initiative, and I always look at the VA Blue Button, and I get so jealous, and my excuse has always been, so correct me if I'm wrong, my excuse has always been because you are insurer and provider, that you have kind of a captive audience in that you have the claims data as well as the clinical as well as the therapy all in one place, whereas we are either reliant on the beneficiary entering the data into their personal health record or getting it from some information repository. Can you put the VA data collection and dissemination and distilling into context for me?
I better repeat back, okay? So I think what you're asking is, how has it been, what are the factors that have caused the VA to be successful with its Blue Button initiative where you haven't seen the same successes elsewhere? So trying to identify those factors, or?
Actually, I just really would like to know, like, do you all gather information from other providers outside of the VA medical network? So that's what I'm asking for the context.
Right, okay. So, and first of all, I just need to tell you that I'm not the Blue Button expert, but that would be Peter Levin and Teresa Hancock. But the Blue Button currently takes only VA data, right, and allows the patient to bring it back and print it, just whatever they want to do with it. But it's only VA data. So I think the direction that we want to go, and we know we need to go, is the ability to take information from other healthcare organizations and incorporate it. So the first step to doing that is standardizing, right? And so the C32 does that. NHIN is working on that. I guess I don't want to say limitation because that's kind of a negative connotation, but the current NHIN thinking is we're just going to bring the data in from other healthcare organizations temporarily. We recognize that's really not what we want to be doing. We want to bring it in permanently so that all of the data can be looked at together holistically to help care for that patient. So what I would say to you is the direction that we're moving is to incorporate data from other healthcare organizations. But again, until you get the standards worked out, you have problems. So that's the reason that I just say we're working very hard with DoD to ensure common information model standards across all of the data. And as a matter of fact, for all of our apps that collect data from patients, we require that that data be standardized using the Intermountain Clinical Element Data Model. So you are not allowed to collect data from patients until you've standardized it. So, go ahead.
Yeah, just a point of clarification. The blue button for the VA has VA data out of their electronic health record, but it also includes any patient-entered data in their mHealth Event personal health records. So, like, if I have some over-the-counter medications that aren't on my medications that are ordered for me by the VA, and I self-enter them, I do get a list that includes both what I put in and what VA has ordered for me. But if I have an order from a physician outside of the VA healthcare system, that doesn't show up unless I enter it.
Right. Yep.
So I think the DoD is in a similar boat. I think they have a CCD off the Chart Care Online that can be downloaded, and I think VA is going to be CCD compliant as of this month, is what I'm told. And I think I just had a conversation actually with ONC because I think there's a problem. So I think while we're headed in the right direction, the problem is how many blue button data are we going to get? Even in DoD, if you just look at it, yes, we have holistic data on the, the patient population that we have. The problem that we face is that 60-70% of the care is still done on the outside. So the providers that are seeing my daughters or whatever, how do they see the data? They don't. Right? So they've been clamoring DoD and saying, we want to see the data. And obviously accessing, from outside the firewalls into the electronic health record becomes a huge issue because we have a larger DoD kind of network for security. And so when I started looking at the blue button and what was happening, clearly I think it was the right first step. We're headed in the right direction. The problem is, even if we made the same data model, let's say you have different medications, and you have 3 different CCDs, what are you going to do with the medication list? Which one's right? And so I think there's some big issues that are facing. So what I'm asking ONC to consider, and I'm going to predict the future, and I'm going to be wrong, but this is what I think ought to happen. I think the healthcare information exchanges should become the national data bank that is 501c controlled, not controlled, but managed, that is owned by the patient. And I think that will fundamentally change this whole equation because then you have one universal set of data which the patients own and share. You can create a set of ecosystem around that. You would have a wallet or whatever mobile phone app that communicates with that common set of data. And then I think amazing things will happen. I know what policies will have to impact is if you have to put in a claim, you don't get paid as a healthcare organization until you send a copy of that to the bank. I think those few things, I think, would really, really change this game. To me, CCD is the right next step, but I think we have to, in parallel now, begin to convert those HIEs and not let custodians of the data, again, being a doctor, I don't think I should be dictating who gets exchanges and what. Why should I have to go ask for my data from 5 different clinics that I've been seen in? It doesn't make sense. So I think we have to do that kind of thing now. And doing that will accelerate all the efforts that are going on.
I have a question for Loretta. Great presentation, thank you. The watch has obviously shown positive outcomes and done really well. But just like with the iPads with the veterans, there's a cost element to this. And have any of the insurance companies, or if you work with insurance companies or whatever, worked out with their patients that because of the positive outcome in certain populations, they are willing to buy this or buy the monitoring service? How is that being addressed, or is it?
Do you want to speak on behalf of the VA as far as their coordinated care? I mean, that's a great question. Where does this fit as far as reimbursement? And the VA has jumped on the telehealth and mobile health bandwagon heavily because this has proven itself as far as the coordinated care initiative for chronic illness management. At the last that I heard, there were 38,000 veterans that had home monitoring systems Perhaps the number is increased by now. And so the VA has determined that because of the outcomes that are achieved, it makes sense to make that investment to then reduce healthcare utilization on the hospitals and outpatient visit side. So the enterprise funds it because it makes sense to do so. In the civilian sector, the Blues will pay for some monitoring, and with ACOs, the new reimbursement models of accountable care organization, one gets a chunk of money to take care of patients proactively, and then you spend it however you see fit. If you want to bring them in every week to the hospital, you can. But now we're seeing that ACOs are looking at doing home monitoring and investing in that for CHF populations and those that are frequent flyers that come to the hospital and are admitted quite a bit. Does that answer your question? Okay, great, thanks. Did you want to comment any on VA home telehealth? Okay, all righty.
Hi, I'm Sharon from the cold, wintry Minnesota that you mentioned. Great panel. Thank you all for the specific responses that you've been giving. What I was really intrigued by and what I've been thinking a lot about is the point that you're making that all three of you echoed about how we engage patients. And I don't mean just in terms of with the technology, but what I hear a lot less discussion about is the gap, that actual instant point between the interface of the technology and the very human response that has to happen. And for that, the critical parts are speed of response, the clinical, very patient-specific content that the responder has. And I am talking not about the watch, the neighbor alert, but the clinician's response. And then also just the quality of that interaction. And I hear and read about instances where there's very cool technology, but there isn't actually great bandwidth to actually respond once an alert has been sounded. And so the actual response comes too late or is actually frustrating for the person who's invested all this time to get the technology set up. The question is, as you've devised strategies, either for your own initiatives or that you've heard of others, how has consideration about the very clinician support of when those alerts happen, how have you factored that in, and what are specific strategies that you've devised?
Well, I guess I'll start. I would say to you, we're not very far along. So the first veteran-facing rollout occurs in January that actually takes the data and brings it back into the healthcare team. So your question, I think, is about how do we design those alerts and that interaction between the healthcare team and the device. That's right. How do we make it responsive? Yes? Or are you talking about the actual decision support algorithms that reside in the app? Which are we talking about?
Capacity and the bandwidth in terms of actually responding once an alert has been sounded or once the patient has actually reached out to the team on the basis of having used the technology.
Yeah. So I think this is really a key critical thing that I don't think we have experience with. I do know this, that one, our algorithms have to be standardized. You cannot have one app responding one way and another app responding another way. You've got to standardize those algorithms. Two, we've got to figure out when is it appropriate to send the response back to the patient or the family member or the neighbor to repeat whatever it is that's caused the alert. The first natural thing is, if your blood pressure is high on this arm, take it on the other arm before it goes to the healthcare team. So again, those are algorithms, but we've got to begin determining, how to standardize those. And then finally, the really big piece is, how do you summarize it and present it to clinicians so that you don't overwhelm them? And that, again, we're just starting on all of that. So I don't have much experience, but I'll pass it along to anyone who wants.
Well, we do have experience, though, with home telehealth. I mean, the VA has about 40,000 patients, and they have a lot of experience in doing this. And I can say that when I worked with the VA on home telehealth, we really did struggle with a lot of these issues, but it's not new. I mean, 6 years ago, we were trying to figure this out. So there are lessons to be learned from what we've already done.
Right, and I just want to comment a little bit on that. The difference between the way we implemented telehealth and the way mobile health is implemented is telehealth was for a very sick population. That data came into data servers that was continuously monitored by a nurse, telehealth nurse, whose job it was just to continuously monitor this stuff. That's a much different model than mobile health, where you have huge amounts of data potentially coming into the healthcare system. So you're right about that. And one of the other lessons we learned from telehealth is we had multiple vendors in telehealth, and they did things different ways, and there was no standardization. And we spent a lot of time trying to fix what we allowed to happen in the beginning, which is we didn't enforce standardization. And like my mantra is, we are not going to repeat the mistakes we've made in the past with telehealth and health and electronic health records. We've got to standardize. Okay.
I just wanted to follow up on your telehealth. What I understand about home telehealth is, like as you said, it's very different. It's not an emergency button when they fall down and hurt themselves. It's a chronic care tool. They check their blood pressure, medication adherence, all kinds of things. The tool that they are using is very intelligent. It algorithmically determines if the patients are adhering to medications, what things they're doing, what their conditions are, and downloads at 3 a.m. educational videos. So at home, they're getting continuous feedback on their actual care. That's really a chronic care tool. And they really leverage this precisely like we had in today's keynote speech, where the modern doctor is looking at the 4 patients for an hour and then looking at a dashboard the rest of the day for the remaining. The way it works in the VA, I understand, is that they have a care coordinator who's coordinating as much as 150 patients every day, one patient, not a physician, who's actually made to truly leverage this technology to do all the care coordination for a huge number of patients, keeping them out of the hospital, preventing diseases, and providing all the feedback that they need, education, medication adherence, everything they need to keep them well and healthy. And this is really precisely what the VA is doing, is precisely what it was described this morning. Question, Dr. Park, about the Bluetooth and CCD technology. Like you said, there's a good number, 50% of veterans who get their care outside the VA, and it'll be key to figure out a way to have a means of getting data in and outside of large, equivalent of VA's equivalent, basically an ACO, de facto, to get the patient's care coordinated in and outside of ACOs around the country, not just the VA, and a method that will like you say, we need to have some standard. And CCD is right now, meaningful use as of last month when it got released, has removed the requirement for exchangeability of medical records between EHRs. So that is no longer imperative EHRs to interoperate. So we got 400 EHRs out there in the wild that don't and won't talk to each other. So this is pushed down to the patient level of what we can do with a CCD of a blue button or its equivalent. Very interested in your thoughts about how we're going to bring this back to the patient, enable the patients to be the custodian of their own data, and whether we need to actually go back to the vendors and say, well, we actually need a common API for these EHRs and a common core database that can be pulled, not pushed or dumped 3 days after the fact, which is the current meaningful use standard, but a real-time pullable set of data. I'm curious about your thoughts on that.
I have a lot of thoughts in my head right now. I don't know which ones I should share, but I do want to answer the question, the question regarding change management. So I absolutely agree that if you look at the EHR and the lessons learned from there, we did not do change management very well. I think Kaiser probably on its second round did it as well as they could in terms of saying, okay, if you have an EHR, what does that mean? What's the impact on the workflow? What data flow goes where? So I think you're absolutely right. There has to be some body of work now that gets started that not only looks at the engagement portion, but what that means to the patient. So there was a study at ATA that was done that really essentially showed one intervention, one control, and the decrease of blood pressure, but the outcome didn't change in either. There was no difference. And the reason was the provider wasn't engaged. They weren't part of the process for change, as they didn't know what to do with this massive amounts of blood pressure data. So I just wanted to echo that. But in terms of the answer, or I don't know, my thoughts is probably better than anything else. So given where we are, I think this HIE and NHIN and the direct and all these things that are going on, I fundamentally now believe that we're taking a wrong approach. I think if we give it to the patient and force the data sharing to be beyond, I don't believe that we can make APIs standard across. I mean, we have HL7 messages and all that, so to some degree we know how to get messages out. But until, again, Judy's going to kill me if she's anywhere in this building, but, as long as Epic's got majority significant, market share, it's going to be hard for her to say, I'll open it up. I mean, it's a business decision that she's making. And so for me, I think instead of trying to fight with vendors and trying to make them the same, because they all come from different ways to solve a problem, I say mandate that healthcare organizations share a copy of the data to the data bank. Once that happens, all the innovations will actually shift in a very fundamental way, in my opinion. But you have to have a policy that mandates healthcare organizations, EHR vendors will then have to abide by releasing the set of data. Because this is a game, this mobile thing isn't about mobile. It's about data, right? It's really all that's about, because mobile now allows us to get data in ways that we've never been able to get before. We get contextual information in ways that we've never had before. So to me, if we can empower it by giving them the data, do that within the set of the contextualization and the standards that Kathy talked about. And then I think you do have to then hold patients accountable. So I think it's a number of different things that have to happen. So for me, just because I have the data in here doesn't change my behavior, right? So again, I think we have to take these actuarial types of models and begin to say, to what degree are we as individuals willing to be accountable? I know that's a big leap, I know, but this is where we're headed. I believe that the employers and others are going to go here. They're starting with an incentive by giving you discounts if you do this, if you do that. I think that will evolve into what I think is the future.
Our time is officially up, so those of you who need to go to another session, please feel free to leave. I think the panelists are willing to be available for additional questions if you would like. But thank you very much for all of your attention. Have a good day.